The Commission will hear two panel presentations on full service partnerships. As you know, the Commission identified FSPs as a priority area for this year. This initial public hearing is meant to provide information about the current state of FSPs across the state through presentations from subject matter experts representing different perspectives. Before we move to the panels, I'd like to invite Commissioner Rowlett to provide any introductory remarks.
Thank you, Commissioners. As you all know, the full service partnerships have certainly been presented by leadership of our state as a solution, a part of a solution to ameliorating many of the unique challenges that California experiences today. Certainly, I want to assert that not every person that is homeless is experiencing symptoms associated with a psychiatric disorder. I want to start by saying that because it's important to understand the unique housing crisis that we have in California is not just germane to people who are experiencing symptoms associated with psychiatric disorders or substance use, or it is, again, a housing crisis that cuts across many sectors. However, for the people or the individuals in our state who do utilize full service partnership services, it's important to understand the array of services, the history, and the commitment made by individuals in the state and in the county. Today, you'll hear from Phebe Bell in Nevada County, who is a wonderful thought leader and a very innovative in how she works in small counties. You'll also, I would be remiss in not acknowledging Dr. Ryan Quist is here from Sacramento County, who has been very supportive of not only the peer perspective or the perspective of people with lived experience, but very responsive to the leadership associated with, again, entities or CBOs that provide much of the mental health or behavioral health service in Sacramento County. My own experience with this has been a bit unique as like with many of you, my family has been touched by mental illness. During the pandemic, I don't share this a lot, but I lost a son who was navigating the effects of affective disorder and substance use. And unfortunately, at the early age of 38, I lost my son. Me, with all the resources that I had, all the things that I could do, I could not change the trajectory of my son's life. That said, I recognize that the people that I'm privileged to work with are not my family. However, this work is unique, and the work that we do in full service partnerships are unique. The partnerships that we develop with the individuals, again, that we're privileged to serve, and cannot be stated enough, it is a privilege to serve. Those partnerships make a difference, not only in their lives, but in ours. It is important, again, to understand that the workforce shortage is causing unique challenges in that area. We do not have the necessary workforce to do the work that we've been challenged and called to do. Another factor that you will be hearing about today. And then lastly, I would be, again, it's important to emphasize data and outcomes, and the fact that there was a commitment to have data and outcomes, and today that a portion of that commitment remains unfulfilled unless you, as a contracting entity, took it upon yourself in collaboration many times with the county to develop data protocols that would inform services going forward. A question that some of you will think about and that will surely be addressed today. I want to say lastly then, and then slightly subjectively, I think full service partnerships work. They work because of the committed work of the individuals that we are serving and the people that are doing the work. My hope is that we not see this as some false panacea that's going to ameliorate every challenge that the state of California it has today. But it is a important part of the solution. And going forward, I know that all the individuals that would be presenting today will provide you with not only insight, but help you as you go forward in making sure that the next iteration of the full service partnership document that was expertly presented by the staff of the OAC is again reflective of your sentiment and includes the perspectives of every person in the room. Thank you very much.
Thank you, Commissioner Rolette. Between yesterday's visit and the panels today, I hope to learn more. I want to say something, words matter. And in the last 2 days, just your commitment and what I saw from the staff and from the members, the word members, I think is very important. So not using the word clients, but members, it just really embraces the spirit of everything that I saw yesterday. And those words do matter. It shapes reality, right? Perception and reality. So thank you for that. And thank you for sharing. At this time, I would like to invite Melissa, to our Chief of Research and Evaluation, to introduce the presenters and facilitate the panels. Am I not? I'm sorry, Melissa.
Okay. Thank you, Madam Chair. And I just want to echo appreciation to Commissioner Rolette, the staff and members of Turning Point Community Programs for a wonderful and informative site visit yesterday. Just a couple of things before we jump into the panel. As has been mentioned, full service partnerships are a core investment of the Mental Health Services Act, and counties are required to dedicate a majority of MHSA community services and supports funding to support these programs. As part of the Commission's mission to support transformational change, the Commission has taken on this project to strengthen these essential investments. Today, we're going to hear 2 panel presentations on full service partnerships. The purpose of this hearing on FSPs is to describe the current lay of the land, to remind us of the original history and promise of FSP programs, and start to identify some of the key tensions, challenges, and opportunities for FSPs within the broader prevention, early intervention, and treatment continuum and broader mental health system. We're going to start the panel with 2 presenters, Dave Pilon and Michael Robinson. Dr. Pilon is one of the original architects of the recovery-oriented community-based programs that we now call full service partnerships, while he was with Mental Health America of Los Angeles. Dr. Pilon has dedicated his career to the design and transformation of mental health programs, and we are delighted to have him with us today. After Dr. Pilon, we will hear from Michael Robinson. Michael Robinson is a graduate of the Pathways to Success After Homelessness program of Turning Point Community Programs. He is an ambassador of FSP programs and offers a powerful testimony about how these services and supports transformed his life. So with that, I'm now going to turn it over to Dr. Pilon to get started.
Thank you, Melissa, and good morning, commissioners. And thank you, Commissioner Rolette, for acknowledging our deep fraternal bond. I appreciate that. Before I start my formal remarks this morning, I hope you'll indulge me for just a minute to acknowledge the lifelong contributions of Richard Van Horn, who passed away a little less than 2 years ago, who served as a commissioner on this body. None of what I've done in my career would have been possible without the leadership that I experienced with Richard, and he was my friend and mentor, and I know his work in the mental health system of California is known to all of us. But it's important to acknowledge what he did. I was reflecting this morning on the fact that it was 34 years ago this week that I was in front of a computer finishing up the proposal that created the Village Integrated Service Agency under AB 3777. And for 3 weeks, my first 3 weeks working at MHA, it was like 16-hour days. I'd go home and I'd sleep a few hours, and I'd come back and I'd go to work for 16 hours writing this proposal. And I was writing it with 4 people: Richard, Ann Stone, Joe Ruiz, Julia Scalise. Did I get everybody? And Richard, yeah. And none of them had had any sort of formal training in mental health or mental illness. I was the only person who had had that kind of formal training, but they were trying to create a program based on what they had already done with in smaller scale out in the community. And I realized in that moment that I had joined a cult. It's like a cult of seeing people for all the potential that they had, regardless of whether they had a mental illness or not. Fortunately, we were, I'll get into that story, but we were able to get it. But without Richard's leadership, without his constant devotion to bringing, services to people with severe and persistent mental illnesses, none of this would have happened. So I just want to acknowledge him. I feel like I'd like to think that he's in the room with us today, and as I deliver my more formal remarks. So thank you for letting me share that with you. Could I see the slide presentation? So I titled this Back to the Future because it feels like every 30 years or so I'm reiterating the same components of the original. This is sort of our village origin story that I'm going to share with you today. Oh, thank you. Appreciate it. So what you need to know is that the village was formed out of Assembly Bill 3777. And the original bill said there was going to be an urban project, a rural project, and a county-wide project. And Merced County got the rural project. We were the urban project, and Ventura County was the overall county project. But one of the major features of that original pilot was that, and I can't emphasize enough how much of a difference this makes. It's that we would get $15,000 per person per year in advance, and no required Medicaid billing. We were going to be judged on our outcomes rather than by any particular services that we provided. We won the proposal. It was a statewide open proposal. And it took us a little while, but we opened our doors on July 1st, 1990. And it was unusual in the respect that you hardly ever see this in community mental health services, is that 120 members were randomly assigned to the village, and by the way, I use the term members as opposed to clients or consumers. They're pretty interchangeable, but it's just the background that I have in terms of the way that I talk, is like members of our community kind of thing. So 120 members were randomly assigned to the village, and 120 members were randomly assigned to a control group. And you never see that in community mental health, but the random assignment allows us to actually make conclusions and draw inferences from the effects of the services, of what village members got versus what the control members got. This is also very important when we talk about what the village consisted of. It combined 2 models of delivering services: the assertive community treatment model and the clubhouse model. Both of those were essential components. And as I'll explain later, I think that people tend to forget. We think it's all about assertive community treatment, and that's an essential component. But people forget about the essential feature of including psychosocial rehabilitation services, which are sort of embodied in the clubhouse model. As I mentioned before, it was a full risk capitated model. So we were responsible not only for the services that people were receiving in the community, but also for their hospitalization. So if somebody went into the hospital, we were on the hook for that cost. And as I'll show you later, that actually incentivized us to reduce the costs of reduce the use of hospitalization as much as we could. And we employed a lot of staff, licensed staff, as you would expect, social workers, psychiatrists, nurse practitioners, but we also employed a lot of non-licensed staff, both at the level where we would talk about things like job developers or job coaches, but we also had a lot of BA level staff who were what we would call community integration specialists, those kinds of positions. And those were oftentimes positions that could be filled by peers as well. The final bullet point there, services were designed to address all aspects of the member's life, not just the symptoms of their illness. Oh, that's pretty small type, sorry. So the independent evaluators findings after 3 years, we actually were under the state funding for a 6-year period, but the study went for 3 years, where the independent evaluator was doing interviews with family members and with the consumers, with the members over that 3-year period of time. And these were the primary results that they found. We had significantly fewer hospital days, for example. And the interesting thing about that is that we didn't reduce the pure number of hospitalizations that much, but the length of the hospitalizations were shorter, because we were able to get people out and get them back into the community a lot faster than the folks in the control group. And this is probably, to me, the most significant result that we saw, is that nearly 3/4 of the village members at some point during that 3 years, they actually tried employment. They got a job. Now, not all of them, kept a job during that time, but that was compared to, what was it? About 15% of the folks in the control group. So we got about 5 times the level of employment results that we did, that they did in the control group. And I won't go into much of the other outcomes, but I will point out that village members reported more solitary leisure activities. They were having fun both alone and out in the community than people in the control group, and they were more satisfied with their mental health care. So people sometimes ask me, well, what do you think was the reason for these differences between the treatment group and the village and the control group? And I point them to this chart and how we spent the money in our budget. We spent about 40% of our budget on what the independent evaluators called case management. I prefer the term care coordination. As Commissioner Roulette pointed out to us yesterday, people are not cases and they don't want to be managed, but we do need to help them coordinate their care. It's like, this is one of the essential components of FSPs, because the people in FSPs are often not able to independently coordinate their own care. And this is the essential service that we offer in FSPs. Commissioner Roulette is right. FSPs work because that's what they do. Okay. So we spent about 40% of our budget on that versus 10% in the control group. Day treatment is essentially the same, medications essentially the same, residential essentially the same. Then we spent about a little more than 10% of our budget on socialization. And you'll see the telling thing is that the next line is outpatient therapy. We only spent about 5% of our budget versus 23% in the comparison group. So folks in the comparison group were getting a lot more therapy. People accuse me of being anti-therapy. I'm not anti-therapy. I guarantee you, I benefited from therapy myself. Okay, but the point is, what do the members want? What it's like, are we making the determination that it's therapy that's important, or are they? And what we found is that not that many of our members were that interested in therapy. We certainly would give it to them if they wanted it, but they were much more interested in the socialization and vocational aspects. And that will, you will see points out the enormous difference between what we spent on what I use the word employment for, but the evaluators called vocational. Literally 25% of our budget went for employment services. So it should be no surprise that you get what you pay for. This is why we got the employment results that we got, because we were investing our resources in that. We spent a lot less of our, excuse me, a lot less of our money on acute hospitalization, as we were getting people out of the hospital faster, and we spent less money on long-term care. So about 4 years ago, I wrote a proposal on behalf of LA County to create a pilot project in your innovation category for Hollywood. It was called a Trieste proposal. Some of you may remember that. And this is a design of what the service system in Hollywood was hoped to look like based on this pilot proposal. And the feature of this that I want to show you is that when we designed this, we moved those psychosocial rehabilitation services up to the top of the grid. You'll notice that full service partnerships are in that row, second row represents our current mental health outpatient sit-in system, from drop-in centers on the left and clubhouses to full service partnerships on the right. And the fact is that there's no current equivalent of of a funding stream for psychosocial rehabilitation services. They're sort of expected to happen under full service partnerships, but I would make the case that this is the part of the model that has been lost in translation to some extent. And so when I designed this proposal 4 years ago, I said, well, I'm gonna pull those out and I'm gonna put them up on the top, because these are the services, psychosocial rehabilitation services like supported employment, supported education, community integration. These are the things that give people or help people to achieve purpose and belonging. It's like, yes, care coordination is essential. It helps people to manage their lives, but it doesn't help them to find purpose and belonging in their lives. And so if it's going to stay in full service partnerships, that's fine, but there has to be some way of ensuring, because there isn't a tradition in all mental health agencies of psychosocial rehabilitation. Many are come from a very much more, it's a psychotherapeutic background, and it's not that they're against psychosocial rehabilitation services, but they feel like they're ancillary in some way. And if there's one argument that I would make, it's that we have to push those up to the top of the grid and say, these are primary, these are the things that people need, and that we can't have a successful system unless we offer these kinds of services in a much more robust way than we currently do. And so these are some of the reasons why I think that we aren't providing them. Is like, if you have one person in front of you who's saying, Dave, you've been talking to me about going back to school for like 6 months, and today is the day I'm ready to do that. And you have another person at the same time who's saying, Dave, I'm about to be evicted from my apartment. Who's going to get your attention, kind of thing? It's the person who's about to be evicted from their apartment. And so we have to have a system that actually dedicates staff and dedicates resources to these kinds of much bigger services that are focused on people's purpose and belonging. The other thing I'll mention is that our current Medicaid system puts up significant barriers to billing for these things. I have been a big advocate for many years for going to a pay-for-performance model, where we actually pay for the outcomes of services. That's essentially what the village was. It was we were not expected to do any kinds of billing on the minute-by-minute basis. We were just expected to get the outcomes. And it really frees you up to do a whatever it takes approach, because you don't have to worry about am I going to get audited because I went and talked to a businessman out in the community for an hour about hiring one of our members. That, to my knowledge, is still not billable under Medicaid, even under CalAIM or something like that. So unless we address that issue, we're gonna struggle with providing these kinds of services. And so the other issue is that we just don't have the staff to who are trained to provide these kinds of services. So these are my recommendations. Explore a true pay for value or pay for performance system that holds providers accountable for their outcomes. And this would have the effect of reducing documentation and billing burdens, provide separate funding streams, decoupled from FSPs if we can't ensure that they're happening in FSPs, for psychosocial rehabilitation services like supported employment, and increase the hiring and reliance on non-licensed BA level staff. As Dr. Roulette mentioned in his earlier remarks, there is a staffing crisis out there, and we are never going to have the number of licensed staff that we need to provide all the services that we do. But we can, if we focus on services that don't require a license, we can find a lot of good BA level staff. We had wonderful BA level staff who could provide community integration services at the village. And we need to move back in that direction. Thank you for attending. Yeah.
Great. I think we can turn it over to Mr. Robinson for your presentation.
Thank you. Good morning, everybody. Good afternoon. My name is Michael Robinson. I'm originally from San Francisco in the Bay Area. Came up here about 17 years ago. I lost my wife in '99 to brain cancer and lost everything. My whole world just fell out. Whole floor was pulled out from under me. I came up here looking to turn my life around, and got back involved with the alcohol, not the drugs, but the alcohol, and was staying out in Discovery Park for about 6-7 years, homeless. Tried to commit suicide, went to Schmick. A young lady from Crisis Residential named Leslie Springer came and talked to me. She said, "You don't need to be here. You need to come to our house." So I went to the house, the Turning Point Crisis Residential House. I stayed there for 90 days, and I left, went through it. They got diagnosed, and didn't know I had a mental illness, but they told me I did. I got diagnosed, got put on medication, and left the place. But I was still homeless. Ended up going back 3-4 different times, 4 more times to Crisis Residential because I didn't know what to do. The only way I saw was just killing myself. They told me, no, there was another way. And I told them, I said, I just need a place to stay. 1 week later, Turning Point had me in a 1-bedroom apartment in the Thomas. I stayed there for 1.5 years. They asked me to move to Boulevard Court. Boulevard Court, I love it now. When I first got there, I didn't. It was real small. I had to get rid of some of my furniture because it couldn't fit in the room. But now, I mean, it's my home. It's my community. Everybody in there I love. They don't all love me, but you know, it's his home. If it wasn't for Turning Point, I'd have been a statistic here in Sacramento. They pulled me out of the quicksand. They tossed me a lifeline, and I grabbed onto it and pulled it out. I jumped off the pathway, and they put me right back on the same pathway I needed to be on. I came to a turning point in my life, and they were there to help me. I thank all of them, all the staff that I've dealt with Turning Point. They've all been there. Anything I asked for, they've done for me. I've had a stroke when I got in Boulevard Court. I was there about 1.5 years. Doctor told me if I didn't stop drinking and abusing my medication, I was going to have a stroke. And I didn't think it was going to happen. I'm a Marine. I did 6 years in the Marine Corps. I'm tough. I can fight this stuff off. Sure enough, it whipped me up. I came to 2.5 months later in the hospital in Carmichael and didn't know what had happened, didn't know where I was. And the first person I called up was Renee McCray, who was my caseworker. And she was in Washington State. And she asked me where I was. I told her, I said, I didn't know. And the next day I gave her the phone number where I was. I found out the name of the place where I was. And the next day, one of the caseworkers were up to see me and from Turning Point. And 2.5 months out, no way. I just felt like I slept and woke up the next day, but it was true. It was true. Turning Point paid my rent for 2 months, which was a blessing for me. I didn't want to lose my place. They were talking about I was going to have to go to a board and care, and I told them, no way, I'll show you I can take care of myself in my own apartment. So I did the physical therapy and occupational therapy and showed them I can put things on the shelves and stuff like that. And they let me go back home. Like I said, if it wasn't for Turning Point and Pathways, I don't know where I'd be at today. I'll probably be, like I said, a statistic today. They pulled me out the quicksand, and I thank them every day. I would do anything and everything for Turning Point Pathways. Thank you.
So this is the end of our first panel. So I think we are open to questions from commissioners.
I just had a comment. If you guys can hear me.
We can hear you. Go ahead.
Okay, I just wanted to thank you both for your presentations and agree with what you were saying about how important the psychosocial rehabilitation services are. I agree it's unfortunate that often it seems like this is such a small part of treatment and services and typically done by case managers, and we never have enough case managers. So it's just something that we're not able to provide for our clients. And I agree a lot of time that has to do with billing because those aren't billable services. I just wanted to agree with that. And then, mention that unfortunately, I think that this is going to get worse with what we're hearing about payment reform, but just really emphasize how important that those services are. And again, thank you both for your presentation.
Madam Chair. First a question and then a comment. My question is with respect to Dr. Pilon. And it's amazing that you spoke about the Trieste model that you worked on and that was put into place, because I was actually talking about it this morning with Commissioner Chambers as we were driving over here. And we were talking about the situation in downtown Los Angeles and how years ago we had a meeting in downtown LA, and I'd driven in the night before and driven through Skid Row and just saw how terrible it was in terms of the situation with so much misery that was down there. And we had a presentation on the Trieste model and the pilot in Los Angeles that was done in, was it Hollywood or West Hollywood? Was it Hollywood? And the mental health director, I asked him, I said, why are you doing this in Hollywood and not doing it in downtown Los Angeles? And he poignantly, I think, said, well, Hollywood has come together as a community and they bought into this concept and what have you. But he said the real reason that we're doing it there and not in downtown Los Angeles is because we wanted to have a chance of success, that the magnitude of the problem in downtown was so great that it was, almost impossible to do. But can you tell us the results of what happened? I understand that it wasn't entirely successful in Hollywood, and what were the barriers and what happened there?
So, first of all, Commissioner, my understanding is limited in that I wasn't part of the discussions, but as the commission will remember, is that LA County came back to the commission and asked for changes to the original proposal, because originally it was to be completely innovation money funded. There was no Medicaid match involved. And my understanding is that LA County thought about that and said, well, we can't afford to leave that Medicaid money on the table. But that's just speculation on my part. I need you to know that. And also the pandemic hit about the time we were trying to implement it as well. And so that caused a lot of chaos as well. But now the county is moving forward and they're trying to, as best they can, to implement many of the original parts of the proposal as possible. And we're even, talking with the county about carving out a little piece of that original proposal and saying, just give us a little bit of it, 5%, 10%, something like that, and allow us to do it without the Medicaid match and see what we can do, see if we can get the outcomes and if that makes a difference, kind of thing. So we're talking with the county about what that would look like and are we going to do it. But just so you know, we're still in the community engagement process. So we're, trying to get that moving, but the pandemic just, destroyed the timelines on that completely. Yeah.
Thanks. And then a couple of comments, actually. First of all, Mr. Robinson, I appreciate very much your comments and courage in coming in here and telling us about the journey that you've had and the success that you've had and the wonderful work of Turning Point. And you are a shining example of the proof that recovery is a process. It's not an event. And, there's so many people that get frustrated by, we want the quick fixes and the quick solutions, just like changing TV channels in America. And sometimes, as in your case, it takes a while, but you've come a long way, and we appreciate you coming today and sharing that with us. And then to Dr. Pilon and his comments, particularly about the village and Richard Van Horn. I have the dubious distinction of being the senior member of the commission at this point, and worked very closely with Richard and was an admirer of him as well. And I just want to say that you did him proud today. And you do. The village concept is really something that's amazing, and you've left a great legacy for him. So thank you.
Thank you, Commissioner.
Just a quick comment and then a question. First and foremost, Mr. Robinson, thank you for being here and thank you for your service. I really do mean that. My belief, Dr. Pilon, what you said around some of the psychosocial rehab activities are pretty critical. I think we have a crisis of culture as much as we have a mental health crisis, and that sense of belonging. But the question I have, you talked about community integration activities and services. Can you further elucidate that? What are some of those?
I'm so glad you asked that question. It's anything that's trying to reintegrate folks into the communities that they may have lost because of the fact that they have a mental illness. So somebody would love to go surfing. Somebody wants to be in a band. Somebody wants to, whatever it is how do we help them to achieve those kinds of things? At the village, for example, we had a member staff band. It's like members and staff playing together, and they would actually go to clubs and play it at clubs. We got into ethical dilemmas. It's like, well, they're serving alcohol at clubs. Should we really be doing this? It's like, the name of the band was called The Delusions. Okay. And I'll give $5 to anybody who can tell me what their backup singers were called. You have 5 seconds. The Auditory Hallucinations. Okay, that was their backup singer's name. Okay, sorry. But activities that there the more formal things like supported education, where we're actually working with employers out in the community. But what I've found is that helping people, so this I happen to be a thoroughbred handicapper. I like watching the horse races kind of thing. I once took a group of 10 members to Hollywood Park to bet on the races. Okay, now everybody's gonna say, what? On their SSI? Well, it's $2 a race. It's like you don't have to worry about that. And the interesting thing was, it was because I was interested in it and I wanted to share that passion with the members, but they, none of them were that taken with it. By the end of the fourth race, they were saying, this is kind of boring. Let's go home. It's like watching horses run around a track. That's fine, but it's the exposure. It's helping people to find sort of like what makes them passionate, what they care about, what their sense of purpose and what their sense of belonging is. And it can be formal things like education and employment, but I also think that, on the Hollywood project, for example, we've got these great resources like the Hollywood Bowl, taking people to the Hollywood Bowl and exposing them to music and those kinds of things. There's lots of people who would like to do those kinds of things, but we don't offer those kinds of things. And I realize that this is a heavy lift on some level, because we're always, as I was saying earlier, focused on the latest crisis that people are experiencing. And that's why you have to have dedicated staff whose job is not to deal with the crises, but is to deal with the purpose and belonging needs that people have. Does that answer your question? Yeah.
Thank you, Chair. First of all, Mr. Robinson, thank you for being here. I thoroughly enjoyed meeting you and your dogs yesterday. It was a highlight. Dr. Pilon, I was equally enjoyed interacting with you yesterday, and I was really moved by this thought. As someone who's not in the system of mental health or even really in government, I think many of us, know that there are lots of needs not being met, and we don't really understand why. And so housing is such an easy one to grab onto, because most of us are lucky enough to have houses, and it's hard to fathom how somebody operates without a house. But there is this kind of illusion. I really realized this yesterday, that we think, well, if we give somebody a house, that's enough. But I learned yesterday it's not nearly enough. And I was really moved by this idea that we need to change the outcome. We have to move to an outcome system, and these outcomes need to be around belonging and purpose, and measuring how many people make their way through this recovery process to education, to employment, to being productively engaged in their communities. And I think that's a powerful idea. But my question for you is this: I look at the January Mental Health Commission report on full service partnerships, and one of the things it clearly says is, despite regulatory requirements, counties do not appear to be allocating mandatory minimum funding levels to support the FSP program. So I'm wondering why. How can they do that if it's a requirement, and why are they not doing it? I assume it's not because they don't think it's a good idea. It clearly delivers needed results. So do you have any opinion about why counties are not adopting? Is it just too hard to do? What is it?
As I said, I think that the crisis in our face gets all of our attention and doesn't allow us to focus the resources on these other things, because there's always a crisis around the corner. But as I'm sorry, I don't know, Commissioner, to your left talked about a crisis of culture. A crisis of culture, because I think that we have to get this idea out of our mind that these other things are ancillary. And that's why I put them up at the top of that grid, is we have to remember that is the aim of services, not just getting people to sort of where they're quote unquote stable or maintaining them at a level of stability, but moving them on in their recovery where they can achieve normalized roles in the community, kind of thing. But it's hard, because there's always another crisis that's going to be, pulling at your purse strings, kind of thing. Yeah.
And so why is it not being adopted more? I get that we're not getting the point. But why are counties not adopting this more?
Commissioner, it's the crisis mentality. I think that's what
It's just
what
the mindset.
The
I think it's a
mindset, the culture, the service culture is that just get people stable. And, you know, I'm glad you mentioned that, because when we created the village, I have to admit to you that I was in that same place. It's like, recovery wasn't even a concept that I was considering when we wrote the proposal back in 1989. I thought, oh, these people are going to be with us for life, kind of thing. And they'll never, you know, truly be back in the community, and we have to provide a really good service for them. But what we quickly discovered when we provided this kind of thing is like, folks are capable of a lot more than we originally thought. When when you hear somebody like Michael's story, you think, okay, now I get it. And, you know, as inspiring as your story is, Michael, I've seen it many times. Many people can do this if they're given the kind of support that Turning Point provides, or, you know, the village provided, or those kinds of things. They can do that. But part of the problem also is that, as Commissioner Rolette said, FSPs are working. We just don't know it because we aren't reporting our outcomes. So it's happening out there, but we aren't. But why aren't we hyping this? Why aren't we talking about this more? When Michael has a success, it should be part of this data gathering where we can actually show, yes, we've had many people who no longer haven't used the hospital in years, or haven't been to the emergency department in years, but we don't have those data to sort of reinforce that with folks. And so, you know, the media being as outrage focused as it is, it's always on the latest crisis that we've had. So I don't mean to, I hope you don't think that I believe that FSPs aren't working. They are. They're creating great results, but we're not putting that out there.
Yeah, I just redouble our efforts as a commission to elevate this work more and to work even harder to get counties to adopt it. Thank you very much.
Please, Commissioner Rolette.
I wanted to acknowledge the issues associated with the workforce challenge that many of us have referenced and talked about. And in particular, Michael, again, thank you so much for sharing your story and your life over the years, and allowing me to engage you in a way that is really in keeping with all the things that we hope to accomplish in the work that we're doing. I would be remiss and to state that Michael and I don't always agree on everything. He's a 49er fan and I am not. That said, I understand the importance of having the workforce available to you when you need it. Renee McCrae, who Michael references, in the audience, and she took the phone call while she was away on Washington that Michael made while he was recovering from his stroke. It is essential. The workforce challenges are compromising our ability to do that, to take those very important phone calls when they are made. And don't miss that point. She was not in California. He was not in the community. But that was that point in time where you really need someone to pick up the phone. And that's what full service partnerships are designed to do, to have staff available 24 hours a day, 7 days a week. The other point that I want to make about Michael, that is, again, an acknowledgement, Michael, of who you are and your commitment, your zeal to continue to give back. Michael is not dependent on specialty mental health services any longer. And that's the goal of full service partnerships. So people are not dependent on those specialty mental health services throughout the totality of their lives. And as Dave said, naively, initially, 32 years ago, he thought, okay, that's the way it was going to be. But it's not. That is not the way we operate. We operate in hopes to support people with flourishing. And so for you, Dave, my question is about flourishing and flourishing scales. And I don't know if the other commissioners are familiar with those. I've been a proponent of flourishing scales as an important outcome measure that is reflective of the perspective of the individual that is receiving the service. If you could say something about that.
So I'm unfamiliar with flourishing scales. Sorry, Commissioner Rolette, but to me, the particular scale is not as important as but that we measure our outcomes, is that we decide what it is we're going to say, and I'd be happy to look at those and evaluate them and say, does this capture what we're hoping to achieve with our members? Because I agree with you 100%. The idea is to graduate people from mental health services. And I know that for a lot of people that sounds fanciful, but it's not. It's like people recover all the time and they don't need the intensive level of services that FSPs provide. But we have to have a metric that allows us to determine that. And if flourishing scales are part of that, that's fine. I'm a little, I have a penchant for my own scale that I created, but that's okay. It doesn't have to be that. It just has to be some metric that we use to figure out where people are and that it's valid and reliable. That's all I care about. Yeah.
And I think that, Toby, my assertion is that we do need to support the scales that really do reflect that we are gathering the data and that we are actively querying the perspective of the individual receiving the services. I'd also be remiss if, Dave, if you feel comfortable saying something about community-defined practices, because there's this, again, it was stated earlier by Stacy, we support community-defined practices, especially those practices that work in communities where individuals are unserved or underserved and have been successful, but potentially are not evidence-based because of a variety of things.
I'm completely in favor of community-defined practices as long as they are in the process of providing evidence for their effectiveness. That is the important criteria for me, is that we have to be evidence-based kind of thing. But obviously, if there are starting up that they don't have the evidence, and so we have to give them the time to develop the evidence as they work their process. But at some point, you have to look at every practice and say, is it delivering on its promise?
And then my last point is about back to you, Michael. I won't ask you to repeat the story, but there was an event that Michael intervened in. Michael referenced in passing, not everybody at Boulevard Court likes me, except Michael did something that every citizen should do. There was an intruder that came onto the property of Boulevard Court. One of the residents at the apartment complex had their door open. The intruder went into an open door, and when Michael and the management of the Boulevard Court property intervened, they found the intruder getting ready to commit a crime, a serious crime. And without Michael's intervention, who knows that if that would have been interrupted. And it is because of you and your citizenship and your commitment to that community that you changed that person's life. And I want to acknowledge that and applaud you. And that's what flourishing is about. You are part of a community, you're invested in the community, and you change the experience of your community because of your leadership. So thank you, Michael Robinson, for being a leader. Thank you.
Just a brief, addendum. I'm compelled to point out that because you mentioned flourishing, it is now in business best practices, HR cutting edge, to be looking at wellness and flourishing as scales that are trying to be accomplished in the private sector. And the fact that we're still debating and even discovering that they should be outcomes in the public sector points to this huge equity gap between public and private that needs to be addressed.
Thank you, Commissioner Carnevale. On that same thought, I wanted to go back, if I could have you, who's handling the slides? Because there's a slide that I wanted to reference. Yes, please. Back. One more, right there. So as I look at this, you know, I'm in schools, so these are discussions that we have. When I look at the scales and I look at, or the numbers, and I look at the village, where the emphasis is really in those categories that I consider holistic, right? The whole person. So in schools, it's the whole child, but it's the whole person. I think about the flourishing. I think about you're addressing those things that bring hope and belongingness. You're addressing that whole person's life. And when I look at the comparison, I don't even see where a human person is being, right? It's the illness. And so that, to me, where is our current practice, would you say? Is our current practice more in the comparison group, or are we more in the village?
Wow. I think it varies tremendously across the system. I think that depending on I think FSPs are probably further towards the holistic than other, you know, parts of the system. But to reiterate the point earlier, it's like it is a culture issue, is that focusing on some level, I feel like we're the victims of our own success, because in talking about recovery, we created a language where people talk about recovery, but they don't necessarily practice it. And they have the words for it. And we say, of course, we're recovery oriented. And then we ask them, well, but how many staff are focused on helping members to get jobs? It's like, well, we won't really have the staff for that, or those kinds of things. So it's really the power of that slide, I think, is that it really says that you have to put your money where your mouth is. It's like you can't. It's not just about saying that you're in favor of recovery or recovery-oriented services. It's like, do those services that you provide actually focus on those kinds of things? And it's not that people are intentionally, not being holistic. They just don't know how to do that, and because we don't have a culture of psychosocial rehabilitation. And Commissioner Carnevale was asking me, well, why don't we have this in California? It's like, and I should have said to you yesterday, it's like, it's not that prevalent anywhere in the United States. There are places where it's more prevalent. Psychosocial rehabilitation actually started on the East Coast, and it was focused at Boston University and that kind of thing. But there have been places that have adopted it, but it hasn't been adopted, widespread anywhere in the United States. And so what I'm asking you all to consider is like, well, should we be thinking about ways to make that a more significant aspect of the way we think about services? And I think that people will embrace it, but they have to be given technical assistance and support in terms of moving toward that system. Yeah.
Please.
Good afternoon, morning still.
Morning.
Michael, thank you for your presentation. Beautiful, totally touched my heart. And Dr. Pilon, I was also looking at that same slide. And so to kind of discuss that point on the practice of why the holistic model is so much more successful looking versus the comparison group. And also to my colleague's question, it's the why. Why isn't the dial moving towards some of these more basic practices that give us these types of outcomes? And I think a lot of it is, it's this draconian thinking in the past of only one thing works, or we're looking at Michael as, how can I say this? Let me go back, because I'm having a lot of thoughts. So right now in California, we're investing a lot of dollars in family finding. So why are we doing that? So I'm in children's health. So we are doing that because a lot of our children who are removed The system says they're taken from really bad families and they shouldn't be put back with these bad people. Well, evidence says that's not true. I have a 5-day-old baby just the other day, Friday, that was removed from their parents. So the system cannot give that 5-day-old what their mom would give them. Again, the thinking is, let's remove this child for many reasons. But at the end of the day, that child still needs to have some type of bonding with their mom. But this old way of thinking, it doesn't allow us to practice practical matters that really help. So I guess my question or comment is, how do we get there? How do we change? Because that's what it appears that we need training, education, very smart people to somehow develop a system thinking change, because that's really the answer to this question. So what is your suggestion or thought? How do we get there to change the thinking to help these models improve, or to those individuals who are doing the work? How do we get there? I mean, that's a big question. I'm sorry I went kind of all around it, but I'm just having so many thoughts on it, because really it just comes down to changing the thinking.
It is. It's a culture shift to a large extent. So how do we help the culture shift?
How do we get to this culture shift? If the change had not occurred with the thinking that Black Americans should be free, or that slavery shouldn't have ended, it's how do we get there? Because those are big tasks, but as you see, they affect people like Michael in such a major way.
Exactly. So as I pointed out earlier, the way we pay for things has an enormous impact on what people feel that they can do, whether it will be reimbursed. And I can tell you that Medicaid does not make it easy to pay for things like employment services. If you want people, I think I mentioned earlier, if you make it easier for people to actually bill for these things or provide these things without the fear that they're going to have the money taken back, then they will do them. I don't think people don't want to provide these kinds of services. It's just that they feel like their hands are tied. It's like that the federal government will take back the money that we pay to do that. Yesterday, Commissioner Roulette was talking about the fear that all provider agencies have, that 5 years down the road, the feds are going to come in and say, oh, by the way, you shouldn't have provided that service. We're taking back $5 million or something along the line. And the risk management that requires for a provider, it's terrible. I can tell you, it's like, it killed me. It's like, when I think about that, it's like, okay, retirement isn't so bad. So it's not that people don't want to do these things. We have put up roadblocks that make it very difficult, if not impossible, to do them. And it's all about the way that we pay for mental health services. I think that's a huge disincentive to providing that kind of culture shift. You're also right, though, is that we have to provide them with the training and the understanding of how this can work. But I'm a believer that, if people were to actually, it was a shock to us. I have to tell you, back in the early 90s, when we saw how people could thrive and flourish if they were just given these kinds of services, none of us from our own experience could imagine it to the extent that we did. And we will see the same thing, but we didn't have those financial impediments that currently happen. And I can tell you, it's like in the 1990s, we had people coming to the village all the time for what we called immersion trainings, and they would look at what we were doing, And they would say to me, because, they would say, well, we can't do this under Medicaid. And in my arrogance, Commissioner, I thought, oh, come on, it's, what's the big deal? It's like, you can do this. It's like, and then on July 1st, 1996, the state of California said to us, you're done. This was great. We're so glad we funded you and you approved this model works. Now we're putting you under the Medicaid system. And we had to then start billing for Medicaid. And I cannot tell you how that tended to undermine the culture that we had created for 6 years. And it was the rest of my career until I retired. It felt like I was fighting a constant battle to hold on to the culture that we had created under this new billing system. And it was really hard. Do I feel like we managed to hold on to it? Yes, to a large extent. But it was so different from that first 6 years because staff were spending 25 to 30% of their time documenting now instead of going out and going to having a band at the local bar kind of thing. It's like so that was kind of diminishing it. I really felt like there was a huge difference that happened at the time, and if I sound like I'm being a broken record on this, it's like the importance of how we pay for things is just a critical component of whether the culture can make the changes that we would like to see. Yeah.
Thank you. Commissioner Bunch.
Thank
is
you.
on, please.
I just wanted to say, I supervise at a very large clinic in LA County, and I do think that the staff are there. Their thinking is already there. The workforce they think in the same way, but people are only allowed to do what they can do, right? So much of it does have to do with the billing. So if I'm at a clinic and if I'm at the clinic today and I hospitalize someone and it takes 4 hours, I can bill for maybe an hour of it, right? Because it's face-to-face. So on top of that, when we talk about, looking at that difference in the graph and looking at even just hospitalizations for so many of our staff who, again, they are a shortage in the workforce, by the time they've kind of gotten one person stable, there's another person who they have to help get stable. So I think that really attributes to what we're seeing in the increase in the hospitalization on the other side of it. But if there is any way that the commission can address these things, I agree with everything that is being said. I just don't know how we go about addressing it.
Thank you, Commissioner Bunch.
So we keep hearing about billing, and we heard that yesterday. Is that something have we taken that on? Is it something that's possible to take on? Is that something we should put on our to-do list here?
That would be a question for Mr. Ewing.
Yes, Toby, let's take it on.
Thank you, Commissioner. The intent of this first hearing, the site visit yesterday and the hearing today, is to create some education and awareness and identify lines of inquiry. So absolutely. The commission is required under the law to provide a report to the governor and the legislature every other year. And so we wanted to make sure we did the report that is included in here. That was more sort of a game plan report because we only had a couple months to draft that. But this really is a chance to identify questions. Staff are documenting, taking notes, and we will then develop a game plan to follow up. The second panel does include FSP providers, so a provider and a county leader. And so these are the kinds of questions would encourage you to bring up during the second panel as well. Thank you.
Thank you, Toby. So at this time, I'm going to ask Melissa to introduce our second panel. And Dr. Pilon, let me pronounce this correctly. Pilon. I'm going to ask you if you wouldn't mind just staying there. Our next panel is online, so maybe there's questions afterwards. And Michael Robinson, please, if you'd like to stay there too as well, that would be great if you're comfortable with that. And we appreciate your presentation. And so we'll listen to the next panel and then just see if we have a discussion thereafter. That's okay. Thank you so much. Melissa, please, if you'd like to introduce the next panel.
Thank you so much. So our second panel will now bring in perspectives from a provider, a county mental health director, and a capacity building and technical assistance partner from the multi-county collaborative on full service partnerships. So I'd like to first invite Lisa Zepeda, who is a licensed marriage and family therapist for Kingsview, working in Kings County. Ms. Zepeda has worked in her community for the last 12 years, and again, we'll be sharing insights from the provider perspective. She's also joined by Fallon Martinez, who is a certified Medi-Cal certified peer support specialist at Kingsview, and she's here to share her perspective as a peer and discuss their role within FSP programs. So Lisa, I'll pass it over to you. And thank you so much for being with us today.
Thank you, Melissa, and thank you everybody online, and we're not in person, but thank you for the invite. We also have David Palunas. He's our executive director for our behavioral service line, so I wanted to also introduce him and his support of him being here. I like to thank you for the opportunity to come and speak and share about our FSP program. We are located in Kings County. I do have a PowerPoint, so give me a moment just to set that up. I know I can share my screen. Sometimes I get a little confused with that. So hold on just a moment. All right. Can you guys see this? Can someone just say, yes, I can?
Yes, we can.
Awesome. Thank you so much. So again, my name is Lisa Zepeda, licensed marriage and family therapist. I am part of our Kingsview organization, and I'm a program manager here at our Hanford location. Hanford is located in the Central Valley, about 45 minutes south of Fresno. I always like to give that description because not a lot of people may be familiar with Hanford. We're really part of a rural community, even further than Fresno. But when I say Fresno, sometimes it gives people an idea of where we're located. So a little bit about who we are, if you're not familiar with Kingsview, is we are a nonprofit organization that was founded in Wrigley, California, and we're located in Central California since 1951 by the Mennonite Central Committee to address the need for treatment of mental health. We have a variety of different behavioral health services that are provided within our organization. Anything from, we have a co-responder triage program for crisis in our Fresno County area. We provide outpatient direct services like with therapy in Tulare County, and I'm located in Kings County. And so I'll be speaking from our full service partnership that we have set up in our Kings County program. And like I said, I'm out of our Hanford location. However, we provide services throughout the county. So different areas such as Avenal, Kettleman City, Lemoore, and Corcoran, if you are familiar with Kings County at all. I put a little map on the screen just to kind of give you more of an idea, more or less where we're located, as well as our county and city symbols. And so I'm really excited to be here. I was not born in Kings County. However, I have been raised and very familiar with the community. So when I went off and got my education, it was a great passion to come back to the community. It is considered a hard to fill area when it comes to clinicians. And so to be able to bring back what I have learned and serve my community, I have a dual passion, not just for my excitement to be a clinician, but also to be able to serve the people in my community and in my county. And so there's some ownership to that, which I think helps a lot with my passion and the sustainability of me being able to serve in this program. I did start as a team lead So in about 2019, the county, we are a nonprofit organization, and we are the contracted provider for adult services in Kings County. And in 2019, or a little prior, but I came into this program manager position in 2019, I was tasked with taking our adult population, which was about 600 or 700 consumers at the time, and was tasked with being able to separate out from what we call different levels of care. So that was for specialty mental health services, our county named the different levels of care, with recovery oriented being at our lowest level, but still those who would qualify for specialty mental health services. And then we have our full service partnership level. And then at the very highest level of need is we do have an ACT team, which is provided, those services are provided by a different provider altogether. So we are a fairly newer program in FSP. So with each year, we have our own set of goals that we're trying to make as we continue to refine it and improve our approaches and services for our members. So just want to focus on the full service partnership level, because I know that's what we were invited to talk about. So for us, the way we view it, and usually how we try to explain it to our members or other community partners, or even different staff who's in our shared building, but they're in different departments, we try to give this information. So we basically tell them it's a program that it's for increased services. It's like a wraparound approach, and really trying to focus on individuals who are at risk of institutionalization. They're homeless or at risk of being homeless. They are constantly maybe finding themselves in that revolving door of the criminal justice system, or have been incarcerated or coming out of jail or the prison system, or who have a high frequency of use of psychiatric inpatient services or access or crisis episodes. So the way we refer into FSP, it's often clinician referred, but it's not just by our clinicians. It can also be from various community partners, such as the jail, our local human services agency. Those are some of the common ones, just to give an example, the superior courts. So we get referrals that come through to us for individuals who have been identified to fall in maybe one or more of these areas. And so the focus of FSP is to, like I said, provide more intensive services, including frequent contacts from our treatment team, which is made up from a variety of different staff members that I'll go over in just a few minutes. But the focus is targeted interventions to help reduce or eliminate those risk factors and really focus on stabilization efforts. So that's just an overview of how we try to describe it to individuals who are maybe not as familiar with FSP in our county, including our consumers that we work with. So the next slide, I'm just going to go ahead and throw up there, is in Kings County, what has been identified as the FSP criteria for individuals who would be eligible or who may be identified to benefit from our services. So it's anyone of 18 years of age or older who's been diagnosed with a serious mental illness. And then we have different criteria based on our TAY population, our adult population, and then our elder population. So individuals who are 18 to 23 years of age, some of the criteria is, well, it's not some, this is our criteria. They are considered to be unserved or underserved, and one are the following areas. So we talked about being homeless or at risk of being homeless. They're aging out of the child and youth mental health system, maybe aging out of the child welfare systems or the juvenile justice systems, or any involvement with the criminal justice system, at risk of involuntary hospitalization or institutionalization, or they may have experienced a first episode of serious mental illness. So embedded even with our FSP program, we do offer a first episode psychosis program, and we work hand in hand. So it's almost like it's dual enrollment with this wraparound approach to providing services to this particular age group. And then we have our 24 to 59 years of age. So you'll see on the screen, there's the similar criteria with regarding homelessness or at risk, involvement with criminal justice system, and frequent utilization of hospital emergency services or inpatient psychiatric hospitalization. And when I turn the next screen, we have the criteria for anyone who then is identified who's age 60 or over. So additional qualifiers would be maybe they were experiencing a reduction in their own ability in their daily functioning, whether it's personal or within the community. There's at risk of out of home care and the need of. So you can see there's some additional criteria for that age group as well. So what our current staffing looks like at this time is we have a clinician, and that clinician also serves in a dual role as the personal service coordinator. So we kind of consider them like the manager. They're the overseer or the team lead, so to speak. So they're the driving force, they're the connector when it comes to the different treatment team, and a guide in terms of what interventions or what may need to be done. And then we have our case managers. And one of the things I talk to our case managers about is they are mighty. And in fact, we have more case managers than we do have clinicians, because they are such a strong component to our FSP team in terms of the work they do with our members. So it's really important that we have a strong case manager presence, and we do. We also have an administrative specialist who's part of our team. I heard in the previous panel presentation, and anyone else who's in the presentation right now who works with FSP, you know that there's a lot of administrative duties, such as the DCR reporting that's collected when working with our clients. And so she is a very huge piece to our team. I let her know that, tell her she's the hub, because she helps us with coordinating and tracking of different things like flex spending, getting that information entered in the DCR in a timely manner, and so much other things. Those are just a few items. And if applicable, we also have a medication services staff that participate, that is made up of both doctors and nurse practitioners, as well as nursing staff and a nursing case manager, and then whom you're going to have an opportunity to hear from in just a few moments. We also have a peer support specialist who is part of our FSP team. I'm so excited about her role and just the work she does. I often refer to her as our member whisperer, because she has such a way to engage clients. Members. I'm a clinician, so I constantly try to reframe my verbiage too. But she just has a unique way in how to engage and connect with them. And I often will have my door open and sometimes can hear just like that human connection, right? It's not all about clinical. It's just like, hey, how's it going? Which I think that social skill component, the ability to connect, is so huge. And she's so caring. I think that a lot of that comes so naturally to her. So you'll hear from her in a few moments. And then, of course, there's a program manager and a clinical supervisor who oversees not only the clinicians, but the case manager. We're part of the team, and we provide that leadership and support for them. We do multiple case staffings per week, just to provide that support and consultation and supervision to help our staff to be able to help the members. So this is a little bit of what our staffing looks like, and I wanted to just provide that. Some of the services we provide. So we try to provide all our services and from a framework of a wellness and recovery based model. So trying to incorporate supportive services that are not only easily accessible, but also culturally competent. We also, at the onset of someone being accepted, well, even referred to the program, we are connecting them with members of the treatment team. And when they're fully enrolled, we definitely assign that team. So that means they'll get an assigned clinician, a case manager, our peer support, they'll be introduced to the team. And again, if medication services are applicable, which most of the time they are, they would also be part of the team and be introduced to the client. Another thing that we try to make them aware of is who their clinician is and their dual role as being that personal services coordinator, as they're that single entity when it comes to just the oversight. And also important, if the member has any type of social support, whether it's family or friends, trying to include them because they're such a huge piece to the members' success. We also work with them in developing a treatment plan. That will identify what are their goals, what are things that will make their life worth living. So we have an idea and an understanding of what they would like to achieve. And so really working with our staff to, yes, we have to be mindful of the clinical component, but also look at the other pieces like the whole person, because that's really going to help us to move forward and align with them to be able to work towards those goals. And so another part of our structure is to try to at least at minimum or average have 3 contacts per week. And that could look like a variety of ways. It could be a contact with the peer support, their case manager. It could be a group. It could be, meeting with someone on their medication team. And again, based on clinical judgment of what the client needs at the time they're at in the program. So what you're seeing on the screen are just some of the different modalities and how we provide those services. So we have individual and group therapy. I talked about case management. So case management could look different in a variety of ways. So we have our case managers who can help them with skills, making linkages to, if there's like needs, linkages to community partners. It could be even working on different areas, whether it's their educational or vocational or employment or social, any other identified goals. So like I said, case management is a huge part of our program. Like I said, we offered individual and group rehabilitative services, medication services. We do lots of collaboration with community agencies, whether that's with the courts, the probation department, human services, the clients involved with CPS or employment training services, formerly known as CalWorks, public guardian, local shelters, local residential facilities. So I could list on and on, but those are some of the common ones. And then educational services to the consumer. So this could be like psychoeducation to their families and support systems. We do have a comprehensive DBT program at our site. And so part of what we do is we provide a free community class. It's really focused on our members' support systems. And so we provide them with a free skills manual and a 6 months class free to learn DBT skills. And we always preface it as this is not so much to have how to teach you how to deal with your loved one. It's more about you also, learning the skills and seeing what they're learning and how you guys can use those skills to work together. And so we open this up not only to family and support systems, but also with community partners. So again, not just treating the member, but also loved ones. So now I'm going to take a little break and I'm going to hand it off to Fallon Martinez, who is going to talk about a little bit more of her certification and some of her tasks that she does.
Hello. I'm Fallon Martinez. I am the peer support here at Kingsview. I'm also a native of Hanford. I've lived all around Kings County. I was born in Hanford, though. I got my certification by participating in a 3-week training that provided me with the knowledge of how to support people as a peer support. And then I took a state exam to become certified as a Medi-Cal peer support. And I also continue my education by attending monthly trainings via Zoom to provide updated information how to better support people as a peer support. One of the tasks that I do as a peer support here is I provide orientations to all people referred to the FSP program. In that orientation, I provide a full description of the program and the services and the expectations of engagement from the participants. I also do weekly check-ins, whether that's in person or I contact them over the phone, just to check in and say, hi, how you're doing? And I interact with them and relate to them genuinely, to provide support and encourage them to advocate for themselves or maybe their needs. And then I interact with the team by providing updates of how they're doing, maybe current needs expressed, whether their contact information has changed, or maybe discussing barriers that they've mentioned that they're having that prevent them from fully engaging in the FSP program. Thank you.
Thank you, Fallon. So I want to go ahead and conclude with our next slide. So again, I just really want to send my gratitude to be able to participate in this forum. You know, so often when we're working, providing those direct services, it could sometimes, because of the work we do and the passion that we have, it could be draining on certain days. And sometimes it can feel like, gosh, who's making these decisions? And don't they see how, you know, it impacts us? So to be able to have this forum and to even know that this commission exists, I'm so excited and I'm so honored to be able to come, to be able to just share some of the challenges that we have encountered and have seen, and some areas that could be opportunities to be worked on. It was very interesting hearing the previous presentation, as well as some of the comments that were made, because I thought, wow, that's a lot of the stuff that I have on my presentation of some of the challenges that we have come upon. So I just like to, they're all listed here, but I kind of like to go over them and just say a little bit of some of what we have experienced here in Kings County. So one of the hugest ones, and I had to put it on there, was of course the housing resources. We just have a very limited, we're a smaller county in a rural area. And so those housing resources are very few and very thin. And so there's not a lot, and that could be very challenging. Sometimes we have, we've encountered, you know, members saying, you know, I'm here for housing, or you guys aren't trying to help me. And it's not that we're not trying to help, it's just, there's just limitations of what we can provide and what we could assist, because it's just not here. It's not available. And even the shelters, there's like a number of beds, so those could get filled very quickly. And so there's a huge need. Another area is funding resources, is the funding is sometimes not there. And so that could, you know, have its own challenges. We don't have a local psychiatric hospital. We don't even have like a PUF unit. Here in Kings County, we rely on the local hospital that is not really set up for to hold some of our clients who have been placed on a 5150 hold, for example. And so it can be challenging even in the experience some of our members may experience if they are in a crisis situation where it may require psychiatric hospitalization, and they're in that like holding place where our crisis team is trying to find, you know, a bed within the state. And so there's some challenges with that, not having the appropriate resources at times for our members. A huge one that we've really seen, I think the pandemic has really increased this, is staffing retention. What we've seen specifically on our team, we have a lot of our members, our treatment team is made up of people who have been at our agency for a long time. And so we're looking at the same team who has themselves continued to, you know, provide services through a pandemic, along with other, you know, just the other stuff. So we've seen a high incidence of compassion fatigue and burnout within staff because of the need. I want to just kind of skip over the next one and tie that into staffing shortages. About a year ago, we lost our FSP team lead to an online platform who provides, you know, services. She's getting paid at a higher wage. She was wonderful, but she had experienced, she had been at the agency for years, and part of it was the burnout. We also lost a licensed clinician in October, and we're still trying to recruit for that position. And it doesn't have to be licensed. We would take an associate level clinician. It just really speaks to the staffing shortages that are out there, that there's so much need in positions, and it's very competitive. You know, back when I was looking for a job as a clinician, it's a very different market now. And so because we're a community-based provider, the competition doesn't make it easier in terms of even when we look at salaries and so forth. So staffing shortages, I mean, even to get enough applicants to be able to interview and to see who would be a fit, it's a challenge. And so I just kind of wanted to tie that in. That's been something we've been experiencing. So as a result, what that means is it leads to more of the task being distributed to the current team. And that's where we can see some of that burnout even being added. I want to go back to the data reporting procedures. So this is another area, I think it was mentioned earlier, that it's important that that data is collected. My recommendation would be, how can we improve that system? It's not a very user-friendly system. I myself had this experience when I was trying to get some IT help. I went through one person and they said, oh, I'm sorry for this, you got to go to this person. So it's very confusing. It makes it difficult and frustrating, especially because a lot of that data has to be entered in a timely manner. So that is also another challenge, to be able to get all that information and put in a timely manner sometimes. Caseload sizes. I could appreciate the state's efforts to try to have this no wrong door approach. However, caseload sizes, I'm not really sure if it was thought out. Again, I'm just speaking from a provider of the infrastructure challenges, that with more doors being open, that means more services for individuals who may have not received services previously. That's a plus, that's a win for us. In terms of staffing, it's a challenge at the same time, because you have this influx of consumers who benefit and meet criteria for these services, just not having the staffing to support it, which then in turns increases burnout, and then also again has increases the likelihood that those clinicians will go off to other opportunities. I think training is huge. I'm a huge proponent for training. I think training not only helps your newer staff feel more competent, but it also helps with some of your more experienced staff. Things are constantly changing, and to have like a training one time and think that's going to be it. No, it's that continual changes, best practices, keeping up to date on what's been found to be effective. That needs to continue to happen. And sometimes going back to funding resources, that means when there's budget cuts, often some of the first stuff that will go is the budget for trainings. Yet to have a more well-trained staff, I think will help them feel more competent, be more efficient in carrying out the services that they do.
Lisa.
And, yes.
I'm going to go ahead and ask you to just, if you could stay with us, but we're going to move on to the next speaker, but I'd like you to stay on for questions afterwards, just so that we can open it up.
Time.
Yes, please.
Yes, absolutely. Okay. Thank you for the opportunity, and I'll go ahead and stop sharing my screen.
Thank you. And please
Absolutely.
stick around so that we can have a discussion afterwards. So with that, I am going to ask Phoebe to go ahead and come on. Melissa, is that correct?
Yep.
Thank you.
Yes. We'll turn it over to Phoebe Bell. Thank you.
Hi, thank you so much. Can you guys hear me okay? Perfect.
Yes, we can. Thank you.
Great. Okay. Hi, I'm Phoebe Bell. I'm the Behavioral Health Director for Nevada County, as well as the past president of CBHDA. And really appreciate the chance to be with you here today. I'm super sorry not to be there in person. The universe conspired to keep that from happening, but glad to be able to be here, at least virtually. And I am going to share a little bit of information around what FSP services can look like in a rural community, particularly, and give some context that way. And I think yeah, there we go. Perfect. So you can jump ahead to the next slide there. So just wanted to start by giving a little context to who Nevada County is, where we sit in the state. We're a relatively small county, and conveniently, we're a population of right about 100,000 people. So as I throw out numbers along the way, that sort of helps with extrapolating it to whatever counties you're more familiar with. We have 3 population centers in Nevada County that are referred to as cities, but the biggest one is 17,000 people. So pretty small, Grass Valley, Nevada City, and Truckee. And then we have the bulk of the community living in the unincorporated parts of the county, and honestly living in pretty rural settings. We have a lot of miles of dirt roads in Nevada County, and people living in pretty rural, kind of spread out situations. And then of course we have a mountain pass in the middle of our county, and I'm sure all of you can imagine that this is about what it's looked like for much of this past winter, at many times shut down entirely. You can jump ahead there. Our behavioral health department is small but mighty. We have 3 clinic sites. This is a picture of our adult outpatient clinic. And importantly, you can't see their part of the building, but we are co-located with our full service partnership adult provider, Turning Point, and we'll talk more about that in a minute. We have a staff. We also have a children's clinic where we're co-located with some other children and family serving services, and then a Truckee clinic where we serve both adults and children. And we have a staff of about 58 folks, a budget of 45 million-ish, and we contract out about 70% of our services to really critical partners. Our contractors are kind of closely held in our system, and we work really tightly together to operate as a system of care. So specifically on the full service partnership side of things, we have 3 key partners. Turning Point Community Programs, Victor Community Support Services, and Stanford Sierra Youth and Families. Turning Point serves our adults, and the other 2 providers serve our children's system. We're going to focus more on the adult side today, but all 3 of these providers are long-standing partners of ours. I think we recruited them all to the community back when MHSA first started, and they've been consistent and really strong partners of ours. I also want to acknowledge, though, that Nevada County is really at the big end of small county land, and that many rural counties actually have 0 providers. We're lucky that we're relatively close to, Roseville and Sacramento and areas where there are more providers and a little bit able to recruit from those areas. And I think the further north you go, the more challenges people have having enough, demand for their services to be able to afford to bring in a full-fledged provider. And so just want to make sure we remember that often counties have to provide their own FSP services because they're unable to bring providers into the mix. Okay, next. So a little bit about what our FSP programs look like. And I know you've gotten a good overview from Kings County, which is great, but so I won't go quite as in depth, but to give it a little bit of a sense of scale, on the adult side, we serve about 75 people at a time in our Turning Point program. We think of it a little bit like slots. That's to keep the low ratios we want to keep of staff to clients. That's about how many people we can fit into our FSP program. Commissioner Roletta, I don't know that you would agree, but I think you would. We refer to Turning Point as really very, very close to Fidelity ACT services, but a little bit more flexible than full Fidelity. It's a really comprehensive array of services, and similar to ACT, it's a lot of the 24/7, whatever it takes, meet people where they're at. Big focus on personal service coordinators and care coordination and management in that way, and just a really, really quality service. I think what's important to note, though, that we really have come to recognize as some of the biggest strengths of our adult FSP program are two aspects of the services that they provide that we have found to be critical in helping keep people stable for the long haul and really limiting the number of people that we need to place into long-term inpatient care. We have really low rates of people in IMDs and MHRSs, and I think it's a lot because we have these two great services. So one of those is medication delivery. So pretty much every day of the week, or literally every day of the week, Turning Point has staff who go out to people's homes and deliver medications to them, watch them take their medications, check on them, make sure they're eating and safe and doing okay, and alerting the team if there's a problem. And it's an incredible intensity of service that allows people to stay well in a community setting and really has been a game changer for a lot of folks. Turning Point also has a lot of housing resources that they manage. Some of those are houses that they own or master lease through MHSA funding that we've been able to bring to the table. Some of those are housing resources that the county has or that are other providers. We have a housing specific provider, maybe they own it, but Turning Point manages it. At any rate, about half the folks in their system have access to housing that we're able to provide collectively. And as we know, that's a really critical element of stability and well-being. On the youth side, we're able to serve 80 kids at a time at Victor Community Services. We tend to have a shorter length of stay in our children's wraparound programs, more like 10 months-ish. So over the course of a year, we tend to serve more people. But it's the similar full wrap around, be there whenever parents need you, families need you, young people need you, and wherever that may be. We really find our parent partners and peer supporters, both in Turning Point and in our youth serving programs, are really critical. And then Stanford Sierra is our smallest and newest FSP program, but also a critical partner, doing great work kind of with other services that are a step down from FSP. Next slide there. So what makes FSP a little bit different in a rural community? Just wanted to highlight that piece. I think you got a good sense yesterday probably of really amazing urban centered FSP programs. And in many ways, we're not that different. But I think one of the things that's hard to kind of overemphasize of what's different in a smaller community is the way in which care can be pretty personalized. Because our numbers are relatively low, we tend to know our clients pretty well across our system. And we tend to be able to really understand collectively between Turning Point and ourselves, or between our children's providers and ourselves. Most often our highest need folks bounce between our systems as appropriate and as needed, and we all get to know them. And we very well might bump into those same clients in the course of our daily living and in our community settings. And it creates a much more web of support that's a little bit more seamless across levels of care. I think, at least it feels that way, just because it's more personalized. And I think also being co-located with our programs, we're able to really have fluid movement back and forth between levels of care, and we can operate not just our kind of treatment services, but also our housing resources and our crisis services, like our peer respite center that Turning Point runs, or our CSU, or our adult residential facility, or some of our many housing resources. We can collectively look together and say, so-and-so's coming out of the hospital. We need a bed at respite. Can we bounce somebody over to that new slot at the housing at Orchard House that just opened up, and that type of thing. And I think that gets to that last bullet, where flexibility has been pretty critical. The ways that we aren't strictly to fidelity, I think, has been because we really strive for that flexibility to be able to really meet people where they're at with the needs they have, and bring the highest level of care that's needed to keep somebody safe and stable in a community setting, and well supported. Next slide. So what are we seeing? What's the impact of these really amazing programs? We see incredible outcomes, and they're very aligned with what the ACT research has found over the years as well. For the 21-22 year, of the 80 individuals that Turning Point was able to serve in Nevada County, 89% stayed housed, 86% avoided psychiatric hospitalizations, 93% avoided arrests or incarcerations, and 18% gained or maintained employment. And I think, you know, as you're aware, we identify people for our FSP level of care who are having a hard time in many of these areas, and typically have a pretty tough history of hospitalizations, arrests, homelessness, et cetera. And so to get to these kind of outcomes is really exciting and inspiring, and I think really speaks to the effectiveness of this flexible, adaptive, supportive, holistic type programming. And to just also say, all of our providers, and staying on the adult side, Turning Point in particular, just come at this work with a deep belief in the inherent worth and value of every human being that they are privileged to serve, and really believe deeply in recovery, in people defining their own path to recovery and what that looks like for them. And it's just a strong program, strong system. Moving ahead to the children's side in terms of outcomes. Thank you. We served 131 youth between our two programs, so a little bit higher rate of turnover of slots as intended, but similar, really incredible outcomes in terms of stability and well-being. Also, we get to see in this front the ways that being supported like this leads to better success in school, which is so important, and also well-being for caregivers and family members. Feelings of connectedness in the community and skills to parent their young people, really increasing and improving, which is exciting. So moving on to, those are the great outcomes. What are our challenges in implementing FSP? Don't mind jumping ahead there. Sorry, I keep clicking myself. So as you've heard already from others, but I can't underscore it enough, probably the biggest challenge we face is around housing. This picture here is a project that opened this past year. That's a No Place Like Home and tax credit and Rural Housing Authority partnership program. We added 40 units of housing for people leaving homelessness, 12 of which are dedicated to people with serious mental illness and permanent supportive housing. Super exciting. We have gone after every grant one could go after over the past year or two. There's been great opportunities to add resources in housing. And as for a small county, I think we've been remarkably effective. I think over the past year, we added 72 beds of housing, specifically for people leaving homelessness, most of those for people with serious mental illness or substance use disorder needs. And we're really proud of that work in those 72 beds. And in that same year, 200 people became homeless for the first time in Nevada County, so it remains incredibly stressful trying to house our clients. I will add that one of the housing units that we added during that past year was with MHSA dollars. We took about $900,000 and purchased a house that Turning Point's operating for us But I want to flag that that's really actually hard to do under some of the current definitions that exist, because that housing, even though it's going to serve FSP clients, doesn't count as an FSP expenditure. We have to continue to balance that 51% of our CSS funding on FSP with our ability to spend on the other side of our CSS bucket. And so when we spend 900,000 on a house, we have to balance that with FSP spending. So when we have, especially when we have one-time funding, it can be really challenging. One-time increases in funding, it can be really challenging to use it for the purpose we know we need, which is more housing. So just want to acknowledge that challenge there. Jumping ahead, another big challenge is workforce crisis. And again, you've heard a fair bit about that, but want to continue to reiterate that. Us and many of our providers are running 20 to 30% vacancy rates in particularly clinical positions, but really across the board at times. Vacancies are staying open for long stretches, which really impacts capacity. And often when we're hiring people with a lot less experience than we ideally would like to be hiring at this point. And I think that's important to flag, just given the challenges of this work and the complexity of this work. And so when we have a more green workforce doing some of the hardest work in our system of care, that creates a lot of stress in the system. Also, just to flag, because we'll turn to dollars in a second, that the vacancy rate issue also impacts our ability to spend MHSA dollars at the rates we plan to spend it at, because so many providers are kind of coming in under budget as they're unable to fill positions and generate units of service, essentially. Next up, this is, I was smiling to myself when some of the earlier conversation was happening around meaning and purpose, because we couldn't agree more. And we know that our providers couldn't agree more either. And we increasingly have been focused on, it's not just enough to help people have the tools they need to stay stable, whether that's housing or other resources, but instead, how do we help nurture people's ability to find their sense of purpose and their connection to a meaningful life? We are in the process of adding IPS, evidence-based employment program, but we've also been really trying to add more and more sort of activities and groups that nurture social connections. This is a picture of one of our youth groups that's a mountain biking group. And, you know, a couple of therapists and a group of young people taking time together in the woods, getting to know each other and facing challenging situations and working through whatever their issues and roadblocks may be, and building and nurturing connection and activity. Those types of things we're trying to do more and more of across our system, and particularly with our key FSP partners. So jumping ahead to the fiscal picture of running FSP programs, I know this zigzaggy chart is not necessarily new to any of you, but I just want to really underscore the challenges of managing MHSA dollars from the county behavioral health director perspective. It's worth saying them out loud because it's pretty amazing. We have no other revenue stream that looks like this. Down 14%, up 64%, flat, down 40%, up 160%, down 34%. Those are pretty wild fluctuations. And I guess just to put that into real dollars in Nevada County, for this current year, we projected to take in about $7.8 million. So a year ago right now, that's what we thought our revenue would be for 22-23. And we plan to spend about 7.3 of that. So pretty much bring in and spend what we, you know, on a par with each other. We're now projecting 4.4 million in revenue, which would be horrifying, except for the fact that we are able to do that, to absorb that decline in revenue without making any cuts in our programs, because we have a little bit of lag time between the revenue coming in and our spending out the door. And so we feel really relieved and proud of our ability to not make a cut in a year like this, and to really try to manage for that through line across the sort of midpoint of these wild fluctuations up and down. And if we go to the next chart, you can see a little bit more what I mean there. It's always a little anxiety provoking to share our detailed financial information, but I felt like it was important to do, to just show you how counties are trying to tackle these ups and downs. So again, remember this year, we're going to probably end at about 4.4 million in revenue overall. Next year, big increase, super exciting. following year back down a little bit. And so we're settling on a 3-year plan level of expenditure that's pretty aggressive, because traditionally what happens is our expenses are coming in a little bit under due to that workforce crisis I was talking about. And oftentimes revenues seem to exceed projections, and we're left holding more resources than we want to hold. And we don't want to. We want to spend, and we want to get services out to people. And so we're going at this pretty aggressively, as I think most counties are, to try to find that midpoint again, to balance those highs and those lows, and to spend responsibly in our communities by the services that we need, but not start and stop programs unnecessarily. Jumping ahead. On the next slide there. So other issues as we look ahead that I just wanted to touch on, topics that we're paying attention to, multiple state reform initiatives, and I'll dive into a couple of those real quickly in a sec, but also wanted to flag the impacts of payment reform. We are in the midst of a pretty significant change in the public behavioral health system and how we are paid for the work that we do. It's changes at a lot of different levels all at the same time: the units of service, the way the money flows, the shift in risk essentially from the state to the county. And it's a big learning process for us. And we are working hard to understand how to make the most of this opportunity, how to support our providers in the best way we can through this transition. And it's a hopeful time, and we all remain optimistic that the future should and could be bright, but it's an anxiety-provoking time because we're not actually sure about that. And it's all about, do the rates work? Are we going to produce units collectively at the level we need to generate the revenues we need? And so it is a very challenging time to plan ahead in the behavioral health system. And I think a year from now, we'll all have a better sense of what that payment reform shift is looking like and what opportunities or challenges it's created for us. And then lastly, that ongoing growing demand for FSP services. Sorry, back on that last slide for one more bullet. We coming out of COVID, and I think I forgot to stress this back on the slide about meaningfulness and connectedness. We know that the demand has never been higher, and this is without adding new populations. We know that the acuity of our clients continues to rise. And I want to add that in rural communities, the isolation that often is experienced based on typically almost zero public transportation, big geographic area that people are spread out around, and lack of sort of population centers to easily come to, having connectedness through services and supports can be really critical for the folks we serve. And so that demand for FSP just continues to grow. Okay, jumping ahead now. So the two state reforms I just wanted to touch on. We know that you'll be hearing more today about the governor's proposal, and we certainly are paying close attention as behavioral health directors as well, trying to understand how some of these changes will impact us. In Nevada County, we're worried about the essentially decline in the FSP bucket. We spend closer to 55% of our CSS funds on our FSP programs right now, and so we wouldn't want to need to cut back our FSP services. I think the opportunity to invest in housing and housing services is exciting and critical and needed. And I worry across the board about sort of the concept of prioritization, essentially as a euphemism for some things we need more of, which means some things we need less of. And how do we decide what we need less of? Because we kind of need it all, is how I see it. And I'll add to that similarly around adding in the substance use disorder population, couldn't be more needed. 100% support adding the type of funding that we have on the mental illness side right now to the substance use side. And I am anxious about doing that with the same pot of money and spreading it across more people with significant needs. So those are the things we're looking at and trying to pay attention to and figure out how to make this work as well as possible to meet the needs that we know are intense and out there, and we are desperately trying to address and serve. And then lastly, the other proposal that we're tracking on closely as well is the DHCS behavioral health waiver proposal, which is also exciting and hopeful and a lot of promise as well. And we're trying to figure out how does the work we're doing now with FSP, that's such a critical part of our system, fit with doing Fidelity Act and our experiences as a state with some of the challenges around High Fidelity Act and the flexibilities of FSP, and yet the opportunity to generate more Medi-Cal revenue for this important work, and all the other aspects of the waiver are exciting, and also going to take some work to make sure that it's all for the positive. So with that, I am happy to answer any questions and appreciate your being willing to hear about all of this.
Thank you so much, Phoebe. We have one last presenter, Nicole Kristy, who is with Third Sector and has been working on the multi-county full service partnership innovation project. And so Nicole, I'm going to turn it over to you and just ask, I know we're a little behind schedule, so we will have your full slide deck, but if you can focus on kind of the high level takeaways from the multi-county collaborative project, that would be great. Thanks, Nicole.
Hi, everyone. Yes, Melissa, understood. I think my colleague Jessica is here with me, and I think she can share the deck to maybe even help expedite things along. So Jess, if you want to share your screen while I just quickly introduce us. Hello, everyone. I'm Nicole Kristy. I'm here with Third Sector, and I am going to present on the Multi-County Full Service Partnership Innovation Project, which is a collaboration of 9 counties working together to improve FSP services and outcomes. Real quick, who is Third Sector and why am I here presenting on this? Well, we're a national nonprofit technical assistance organization, and we have supported this project and continue to support the project over the past 3 years. So my objectives today were to give you a quick overview of the project and then discuss some of the similarities and differences in FSP programs across our participating counties, and also share some key takeaways from the project and thoughts on how we can continue capacity building through technical assistance to improve FSP programs. Noting the time, I'm going to go through this a lot quicker than I had anticipated, so bear with me. But I'm always happy to answer questions after the fact. So real quick, how did this get started? So, FSPs, we've talked a lot about how they take a whatever it takes approach. And because FSPs need to be tailored to the individual, counties are provided a lot of flexibility in how to operate, which really support community responsive services, but that flexibility can sometimes create inconsistent processes and data, which can make it challenging to understand the overall impact of FSPs, especially across the state. And so the Multi-County FSP Innovation Project grew out of that challenge. We first did some work in LA County to transform their FSP contracts to really focus more on member outcomes and incentivize serving those who are hardest to reach. And then in 2020, we had 6 original counties, Fresno, Sacramento, San Mateo, San Bernardino, Siskiyou, and Ventura, in partnership with the MHSOAC, Cal Mesa, RAND, and Third Sector, launch this innovation project to build off some of LA's work. In the fall of 2021, 2 additional counties joined, Lake and Stanislaus, and Napa, our 9th county, joined in the summer of last year. Next slide. I will not read the project goals to you, but at the end of the day, this project's really trying to help counties improve their ability to collect and use FSP data in a meaningful way to really understand who is being served, how they are being served, and if they are better off as a result of those services. Next slide. So here's the timeline, the general timeline. It's a 4.5-year project. And essentially in 2019, we started planning for this innovation project. In 2020, the project officially launched with those original 6 counties. And the project's divided into 4 phases. So we have a landscape assessment phase where we really gather context within and across the FSP programs we're working with to explore similarities and differences. We then move into design and implementation to design solution to some of those challenges that are identified and create more consistency and some improvements within a local context. We have a sustainability phase that ensures counties can sustain this collaborative and continuous improvement processes that incorporate stakeholder voices, especially providers and members. And then finally, there's an evaluation phase. And so right now, the original 6 counties are in that evaluation period. RAND is the evaluator, and they're doing both quantitative and qualitative analysis on the project. The counties that started a little bit later are on this same structure, but a little bit of a different timeline. So I'm going to go real briefly over each of these phases to give you all an understanding of what the project is focusing on. During the landscape assessment, I mentioned we're really trying to explore similarities and differences across FSP programs, and we did that through really extensive engagement with county leadership, staff, providers, and members. That was really a core value of this project, and you can see some of the numbers of folks we engaged on this slide. We really examine the full spectrum of an FSP program, from enrollment and eligibility criteria to graduation processes. And we saw a lot of variation in programs, both across providers within the same county and also across counties. We also saw a lot of common challenges. So for example, most counties didn't have a consistent graduation guidelines or measurable metrics on how or when to step a member down to a lower level of service, making it difficult to make some of those graduation determinations. Data collection and reporting practices also varied significantly across counties, but all counties shared some kind of challenge around getting the data that they needed in a timely manner to really understand the results of their program. Now, this is not to say that all variation is bad. It is not, taking a whatever it takes approach often means needing to cater programs to the needs of individual members. And the counties in this project were very different. We went from rural and frontier counties like Siskiyou and Lake to much larger counties like Sacramento and Ventura. And these differences meant that programs needed to have slight variations. I think just like Phoebe was mentioning, especially in rural counties, it really does matter, the context of the population in the county. There were some things, however, that the counties agreed should be made consistent, and that's what you see on this slide. So based on all of the information that we gathered during the landscape assessment, we came back together and we started the design and implementation phase. And this phase was divided into 2 groups of activities. One was all the participating counties worked on a set of things together as a cohort, and then each individual county also worked on activities to address things within their local context. So what you're looking at here is at the cohort level, all counties worked together to really try to standardize population definitions, outcome and process metrics, and also make recommendations to improve data collection and reporting across the state. So I won't dive into these details just for lack of time, but I do want to mention some of the outcomes that the counties decided to measure in a consistent way were increased stable housing, reduced justice involvement, reduced utilization of psychiatric facilities. Those all probably sound familiar, but they also added increased social connectedness. And that last measure is especially exciting addition because it was elevated directly by FSP members as an indicator of their own wellness and recovery. Next slide, please. I mentioned the other part of the design and implementation phase was counties working within their own local context. And so each county picked 2 or 3 local initiatives to improve their county-specific FSP programs. You can see on this slide, it was a wider range of things counties decided to work on. Step down in graduation guidelines was a very popular one. I think as process redesign on that was really heavily based on member and provider input. So, as a consistent TA provider, third sector was actually able to elevate a lot of best practices across counties. And so while not all of the final outputs of that activity were exactly the same across each of these counties that worked on it, there were foundational principles, and we were able to really effectively and efficiently share tools and processes and ideas across the cohort so that the cohort could benefit even if there were nuanced results. Next slide, please. And then finally, I mentioned there was a sustainability phase, which was really meant to just ensure the long-term success of the efforts. And then RAND at the end of third sector's technical assistance begins the 2.5-year evaluation. So I will just end on a couple of lessons learned from this cohort so far. We really came away from the project with a strong feeling that the cohort model offered a lot of great opportunities for cross-county work, while also balancing the need for individualized support based on local county context. So there's so much value in doing cross-county work, especially when there's shared vision and goals. And at the same time, each county has unique needs, and it's important to recognize those and identify when standardization is appropriate and when it may not be appropriate and local nuance is really needed. I also just want to highlight that the cohort approach created a lot of additional space for informal connections that have been really valuable, and I've watched the counties continue to connect in an ongoing way. One county has a specific challenge and then they bring it to the group, and the group is able to discuss, what's going on in different counties and share information in a really meaningful way. And then finally, what do we see in the future here? Last slide. So, we did a lot of great work on this project. We started back in 2020, but there's of course still more to do. And as we think about a statewide vision for FSPs, we see a lot of opportunity to continue to expand community engagement, continue to involve community voice and decision-making, increase the amount of knowledge and best practices that are shared across the state, not only within these 9 counties, and to really grow capacity that is so desperately needed, as we just heard from Kings and Nevada, through coordinated technical assistance. I won't go into too much detail here for time, but I do want to just name, we are having another statewide learning community on May 25th, and the registration for that event will be going out in another week. So with that, thank you so much for having me. On the next slide is my contact information, and more information is available on Third Sector's website. I'm sorry that I had to speed through that so quickly, but we will stick around for questions, and you can always reach out to me directly.
Thank you so much, Nicole. So that concludes the panel presentation. So I think we can move to commissioner questions.
Thank you. Thank you, Melissa. I see Commissioner Carnevale, please.
Thank you, Chair. A comment question for Third Sector and then also for Nevada County. Regarding Third Sector, first of all, thank you for adding the increased connectedness. That seems like a movement in the right direction. I was going to ask Dr. Pilon, you're encouraging those outcome measurements, but I didn't hear specific measurements. I'm wondering if you have specific measurements you might recommend that this group consider to expand even more aggressively in that direction.
So I was really excited to hear that too, Commissioner, and I'd like to join that biking group. It sounded really, it sounded really good, actually. In the Third Sector presentation, there was also the report about looking at social or self-reports of social connectedness. So there's a commonality between those two things. And when it comes to that, I think that self-report of are we actually creating those kinds of social connections is a fine way to go. There's not a problem with that. It's like if it's obviously the members are realizing that increases their overall health, and that's a good way to measure that, I would say. Yeah.
But what about outcomes around, you'd mentioned education and employment? How do we?
Are they going back to school, or are they getting jobs?
Are those literally the two measurements?
Absolutely.
Yeah. So I would encourage the group to think about expanding in those directions, because those are literally the outcomes we're trying to get to. So let's measure them rather than pieces that build toward that alone. Moving to Nevada County, to Phebe, I guess, this is such first of all, again, congratulations on running such a great set of programs. But we're listening to the challenges, and it's trying to unbundle them and then decide, okay, what do you attack to help solve some of these challenges is a little bit confounding to me. It seems like one of them is around money and funding and so forth. I guess I wanted to ask Phebe first, is the problem that you don't have enough money, or is it the flexibility around the money? And I heard from Dr. Pilon this idea that coupled from Medicare and being able to spend without categorization, if I understand that, would have been more successful. And I hear it sounds like there's some innovations coming that might start to do that. But is which one is it about, or both, or is it something else that I don't understand?
I think I would say from my experience I don't want to pretend to be an expert in every county's experience with MHSA, but it's both, both and. In Nevada County, if we had more money, we would serve more people, provide more housing, provide more comprehensive services, all of it. And it's the flexibility to be able to more nimbly move between our sort of current existing buckets to be able to meet the needs of the day. You know, I don't think when the buckets were created 10, 15 years ago, we foresaw the housing crisis that we have today. And so being able to flexibly address that need when we have unexpected revenues, one-time revenues, and want to spend them quickly to meet an urgent need that the people we serve have. So it's being able to do both, have the pot be bigger and have the flexibility between sort of buckets be more fluid so that we can adapt as needed.
So help me understand, you're indicating a lot of variability and not enough money funding, but when I look at our own website and I look at Nevada County, I see that there's $110 million of unspent money, and that's going to grow substantially, it looks like, over the next year. And if there's a shortage of housing, why is the county not taking some of that money and spending on housing? That doesn't have to go to the existing budget. I don't understand why the budget is so limited, and we sit here trying to figure out how we're going to explain to taxpayers who've paid money into the system to solve mental health crises, and the money there are billions of dollars being left in the system unspent. Can you help us understand that better from a county viewpoint? What are we missing here?
So first off, I'm pretty certain we don't have $110 million, but if we do, I missed it and I want to find it. I think the things to recognize, and I hope that zigzaggy revenue chart helped highlight this. It's really hard to spend the money in the year it comes in because you don't actually know what it's going to be, and it most often misses whatever it was projected to be pretty substantially. And so we're setting our spending goals based on projections that are unstable and that are volatile. And so again, like in Nevada County, we've set our next 3-year spending goal at about $7 million, which is less than we'll take in next year, but $3 million more than we took in this year. And that feels like a pretty fair place to aim for. So first off, there's that, like managing a very volatile funding stream in a responsible way. And again, so that we could get through a year like this with 40% less revenue than we planned on having and not cut a single program in a time when we couldn't need programs more than we currently need. So the revenue fluctuations don't relate to the demand fluctuation. So that's a challenge. But secondly, it is it's the rigidity of the current pots in which we have to spend money. So again, after you take off innovation, 80% goes to CSS, 50% of CSS has to go to FSP, which means you have 50% for general systems work. That's where your housing purchases can happen out of. But if you have, $4 million of CSS and you're spending $2 million on FSP, but suddenly you have $5 million this year because you got more revenue than you thought, you can't boost your general services spending to purchase a house because now your ratios are off and you're not hitting your 51% on your FSP side. And, I can't call Commissioner Roulette up in the middle of February and say, can you increase your program by $500,000 this year so I can buy a house on my other side of my bucket? It does, programs aren't nimble in that kind of way. And so you get stuck in ways that you don't plan to get stuck. Does that make any sense? Sorry, it's a little in the weeds.
Yeah, well, it makes sense. And I understand that challenge. And it looks like maybe I've gotten the wrong figure. It's not 110. That includes several counties. So the number is probably smaller, but there's definitely unspent funds there. And if it were 10 years ago, I'd understand the argument that you don't know what's going to happen over the next year, but the money has only gotten bigger and bigger and bigger and bigger. And there's close to $3 billion now in the system. It looks like it's going to grow to over $5 billion. And in Nevada County, I'm sure it's significant. So I would just encourage you to look at that number again, and maybe all counties need to be more aggressive in thinking about spending that money, because it looks like it's not going smaller, it's only getting bigger. So something I would encourage you to look at. Thank you.
And I hear you, and I think every behavioral health director is right there with you in like the need is urgent and the need is now, and people are suffering. There's no question about that. But I'd encourage you also to look a little bit globally. Like when we look at reversion, counties are given 3 years to spend MHSA dollars because, again, it's so volatile and it's so hard to predict, in the same ways that the state struggles with spending unexpected revenues in the same year it comes in. And when we look at reversion, less than 1% of all MHSA dollars revert. Counties get the money out the door in their legally required timeframes. But specifically in Nevada County, we've worked with our community to set sort of a buffer that we all feel is important. So we typically have about 50 to 60% of a year of expenditures in our unspent funds, so that, again, when we have a year like this that ends up down 40%, we continue onward. We have the money, we'll overspend. And as you could see from our 3-year plan, we're planning to aggressively spend moving forward, because some of those projections continue to not hit the mark, particularly around expenditures in a workforce crisis. And so I think that I would argue directors are doing their utmost to spend this money effectively and efficiently, and we are. And I think you heard today about the impact that those expenditures are having on really important and incredible programming.
And Phoebe, I stand corrected. I got the corrected numbers, and it turns out Nevada County actually is one of the best counties at spending your money. So I've beaten you up for the wrong reasons, but I'll take advantage of you as an example of many other counties are not spending their dollars, and so the argument is the same. It's just not to you. So thank you for the hard work that you guys do.
Thank you.
Hi, Phoebe. This is Al Roulette, today Commissioner Roulette. You referenced in your presentation that 80% of your services, approximately, it was actually 79 that you had on your slide, was contracted. And I believe that necessitates a particular type of approach where contractors or non-government organizations like Turning Point, and I again acknowledge that Turning Point has been a longstanding partner in Nevada County. But from our perspective, the approach that you take works, and that it's a partnership that one of the most important features of which is a degree of transparency that I think at times makes us both uncomfortable. Could you talk about that? And I think that it's necessary, by the way, and I say that for everybody on the commission, that because such a vast percentage of the services in California are contracted, that this notion about transparency that's achieved in Nevada County makes the working with Phoebe, as I've said to her, even when we disagree, it's a disagreement that's predicated on facts and transparency. Could you talk about why the department has taken that approach? And again, I want to applaud you. I think it's very successful.
Sure, thank you. And yeah, that's obviously a two-way street. I think from where I sit, we need our providers more than you need our funding, really, because money without people doing amazing work is just money, and it's not going to help address the needs that we all have out there. And also from where we sit, the more sort of doorways into support that exist, whether it's, the literal Turning Point doorway or Victor Community Services doorway or whatever, versus just the county building doorway, the more access and options we have to give community members that are more comfortable for them. Lots of people don't want to walk in county buildings. Lots of people want to find somebody that is more comfortable, has shared experiences with them, looks like them, has lived experience like theirs to connect with first and foremost. And so anyway, I guess like starting from that place of like, it's a mutual dependent system. We have to work together. We all need the knowledge of what the big picture looks like so that we can trust that we're all making the best decisions we can for our communities and the people we serve. And that only happens when we're able to like share information honestly and partner in making the hard decisions, and at least hear each other's input on those hard decisions. And I think, I really want to stress, I have gotten to know all the behavioral health directors over the last handful of years I've been doing this job, and there's nobody out there with bad intentions. Everybody wants to do the right thing for their communities with their partners. And it is really hard and complicated work. And we are only as strong as sort of all of us together can possibly be. The collaboration is critical to the system well-being.
Well, again, I would endorse, Phoebe, that you continue to advance all the proponents of transparency, specifically as it relates to the relationship between yourself, especially in this new era under CalAIM and payment reform, that you advance now very successfully, because ultimately, again, in conclusion, it's the end user, the consumer, and in Nevada County, you get to see them because it's a small community of 100,000 people. And so it makes a difference how we engage the funding entity or the county, and in Nevada County, it is an experience that works. And so I wanted to emphasize that for all the commissioners today.
Thank you. Just a couple of things. I wanted to acknowledge what Lisa had talked about regarding the workforce shortage. And when you have agencies, they're losing staff to agencies that are providing, Lisa, if this is correct, and I don't know if you're still on there, but providing telehealth services. Was that correct that you mentioned that you're losing staff?
Yes, to the private sector, going into private practice and working for online providers.
Yes, and I think, there's this discussion because we're seeing more and more of the telehealth services that are being provided and being offered even in our school communities. And so I think that, it's something to think about, that's another, it's really weighing on the system. So thank you for lifting that up. And to Phoebe, I'm looking at the slide and your statistics, you're knocking it out of the ballpark. And I'm wondering, for those that you served, was there a waiting list for those that are not being served? I'm just wondering, you were serving the 80 individuals and then 131 youth. And I love that you included the academic performance, it goes back to exactly that, right? Staying engaged in schools, and for adults, the employment. So are you meeting the needs of your community? And I also noted that you said, just if I'm right, the 200 people for the first time this year in your community are homeless. Is that correct? Is that what I heard you say?
Yes, exactly. In our last point in time count, we identified 200 people who became homeless for the first time during that year. And then in terms of your question about sort of wait lists, it's not like that. There's nobody waiting for FSP level care that's not getting services. It's just we're supporting them with our normal outpatient clinic staff, our own case managers and therapists and psychiatrists, et cetera. But do we have more people who would benefit from a more intensive level of service like our FSPs are able to provide? Definitely.
Well, I want to congratulate you. I mean, these are just very impressive what you're doing there. And, for all the work that you're doing, it just really congratulate you. And Nevada County is, benefiting from the great work and the partnerships there. So thank you. And thank you for being here. I want to thank everybody. Lisa, Fallon, Phoebe, thank you for being here. And of course, Dave and Michael and Nicole. Did not forget about you, Nicole. So thank you all for being here and taking the time to inform us. And we will continue to look into this and see what we can do. And I'm sorry. Oh, no. Thank you. So we are going to move forward, and tell me if I'm missing something. Yes, we are going to ask now for public comment. If there are no other questions or comments from our fellow commissioners, we're going to ask for public comment. So Amariani, if you would like to please, at this time, members of the public may request to make a public comment on agenda item 6 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. And I will ask that you please limit your comments to 3 minutes or less. Mariani, please open the line for public comment on agenda item 6, and let's start with comments from within the room.
Okay, we have one comment in the room. We have Stacy. You can go ahead.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Great presentation. I especially like the presentation. I'm because I was with MHAC. So thank you, Michael, for your story too. In the interest of time, I'm going to make it really short. I really suggest you look at the recommendations that Dave Pilon gave you, because I think they really hold true for not only this is what I was delighted, huge, because I visited the village several times. It's a huge program. It's a huge place, but these recommendations, and especially your comments about how going toward Medi-Cal really changed the nature of your program, and it was very difficult, holds true for so many of my racial ethnic organizations that serve those particular communities. Everybody wants to push them to Medi-Cal, to get that dollar. Yes, we don't want to leave dollars on the table, but they said, Stacey, this is changing the nature of exactly what you said. It's changing the nature of the program. One of the best programs they have, I won't say which, they almost went under because their workers, everybody hated what they were doing compared to before, when they weren't trying to get Medi-Cal. And with the governor's proposal to try to push more Medi-Cal, again, of course, it's all because we want to save money. But if it's going to change the nature of the program to where it is just, again, the MHSA was to transform the mental health system. If we're just going to go back, it's the wrong direction. So thank you.
Thank you, Stacy.
Online, we have 3 public comments. First, we have Dewan. Your line is open.
Thank you. I'm not sure if you can hear me okay?
We can hear you.
Oh, perfect. Okay. Thank you, commissioners. I had in my notes, good morning, but it's good afternoon at this point. Dewan Utek, I am the director, the Chief Development Officer for Telecare Corporation, previously the Director of Behavioral Health for the great county of Fresno. Happy to hear them get some funding this morning. Thank you for your focus on FSP, such an integral part of the behavioral health continuum of care. Telecare is a person-centered, recovery-focused statewide provider operating since 1965, offering services in 23 California counties and in Washington, Oregon, and Nebraska. Over 50 of our 135 programs offer full service partnership or assertive community treatment levels of care. We are one of the largest providers of FSP and ACT services in California, serving over 15% of the FSP served population in fiscal year 2021, which was referenced in the Commission's report. Our full service partnership and ACT serve over 9,000 individuals annually, including transitional age youth, adults, and older adult populations. We have specialized teams for justice involved persons, including those under a Department of State hospital or misdemeanor diversion, and persons experiencing homelessness. Our systematic approach to care strives to empower those with the most complex needs, no matter the setting. We participated in the state's first pay for performance program for FSPs in Santa Clara, Partners in Wellness, which just ended the last year, largely because it was successful and enabled Santa Clara to greatly grow their FSP programming. Our programs do adhere to FSP and ACTs to deliver intensive outreach to maximize engagement in partnership with those served. The people we serve have the most success in supporting their recovery when there are complementary pre and post services, robust and complementary transitional and permanent supportive housing options, and the psychosocial supports that were previously mentioned. A robust continuum in a community ensures that clients progress through the levels of care to support right care, right time, right setting. When this happens, we see upwards of 60% of individuals having stable housing and or transferring out of an FSP to a less restrictive or less intense level of services. One recommendation is to move away from a fail-first system of FSP referrals. Currently, to qualify for a referral, folks must have repeat hospitalizations, incarcerations, or crisis visits, as you heard earlier. While the need for an FSP is clear for these individuals, less rigid criteria could increase access to services earlier in their course of care. Another challenge in the policy and practice arena is the need for a statewide credentialing system. Delays in credentialing can limit the ability of providers to quickly deploy scarce staff and increase access to care. Another challenge is the manual and at times arbitrary nature of data collection, developing the standardized data sets that were recommended across the system, not just for MHSA, which could be built into electronic health records and then uploaded or transferred through an information exchange would improve data collection, data validity, and help drive a more data-driven system of care. Further, the elimination of superfluous data collection increases the available time for scarce staff to focus on person-centered, recovery-focused care. To build capacity, it would be helpful to understand if there are certain approaches or modalities that would better benefit. Thank you.
Thank you.
Next, we have Patricia Moreno. Your line is open.
Hi, thank you. Good morning, Commission Chair and members. My name is Patricia Moreno Gonzalez, and I'm here on behalf of the California Council of Community Behavioral Health Agencies. CBHA is a statewide association of nonprofit agencies dedicated to providing mental health and substance use disorder programs and services to those in need across our state. Some of the members that we represent are full service partnerships and are also sitting on today's panel. We strongly believe that full service partnerships foster the much needed capacity to serve adults with severe persistent mental illness. We're in full support of the comments that were made by Commissioner Rolette and discussing the importance of FSPs and the work that they do for different communities. Thank you so much.
Thank you, Patricia.
And our last public comment, we have Laurel. Your line is open.
Just trying to get my video on. Why not? Why is it? There we go. Okay. All right. So this is Laurel Ben-Hamida. I realized I forgot to introduce myself earlier when I was commending the commission on the information notice about PEI priorities. I am with Muslim American Society Social Services Foundation in Sacramento and with REMCO. I first want to say, yes, thank you. MHA has done so much in the past. It was Richard who gave me the first opportunity suggesting that I apply for the CLCC committee when I was just getting started. Stacy was mentoring us. And Rusty Felix was encouraging us to be at the table. I especially appreciated and will recommend the first panel, not because the second panel wasn't good, but the first panel gives the background that a lot of young advocates or new advocates need to know as they learn about the MHSA and what's been done by the people who laid the foundation for the work that's being done now. And of course, the information about today, some of it we know because we run into workforce issues too, and so on great needs. So thank you very much. Worthwhile panels.
Thank you, Laurel.
That was our last public comment.